And that recording will be sent out probably sometime tomorrow morning. Also attached to that recording is a questionnaire. We just ask that you take the time, fill out the questionnaire, and we value your opinion as students and alumni of WGU, so we obviously want your feedback. So if you could please just fill that out, we would greatly appreciate it. You're able to go back, reference anything that is covered during the presentation. So if you're jotting down notes, you can always go back and rewatch the recording. The chat is open, so if you do have questions, feel free to post those into the chat. Or if you would like to jump off mute, I know that we'll have a designated Q&A. I know we're looking for an interactive type of session here. So if you do have questions, feel free, take yourself off mute or post those into the chat. Without further ado, I will pass it over to Haley.
Hi, thank you. If you're okay with that, I will share my screen, but I do want to give a moment to follow those QR codes if anybody is participating and wants those. I didn't make this presentation, so I'm not going to take credit for it, even though my name is all over it. Somebody was very kind and made this for me. So hold on one second. We'll see how technologically savvy I am. Okay, can you guys see my screen?
Yes.
Perfect. Okay. Well, again, my name is Haley Frankovich. I am the ED nurse manager for our emergency department for here in Boise, St. Alphonsus Regional Medical Center, as well as our freestanding ED in Eagle, Idaho. How many participants here are in the area? Feel free to put it in chat or come off mute.
I like that. Let's post it. Where are you checking in from today in the chat?
Miami. Ooh. Indiana. Nice. Las Vegas. Okay. Cold Detroit. I bet it's cold. I am not one for that. Nevada. Great. California. Okay. While everyone's still popping those in, so I am in Boise, Idaho, and I run the trauma center up here. That's a level 2. We'll get a little bit into my background and why I kind of came into healthcare in general, but I just want to tell a little bit about our medical center because I'm very proud of where we work. St. Alphonsus is part of a mothership company called Trinity Health. We are a nonprofit organization and we are mission-based healthcare system. That is very important to me, especially working in healthcare, to have a culture and roots that we can tie down to, and to find a healthcare or a system that matches your own mission, values, how you want to operate, and the kind of care and practice you want to deliver to patients. St. Alphonsus is in 4 locations. We have Boise, Nampa, Ontario, and Baker City. So we serve 2 states, Idaho and Eastern Oregon. We have 75 clinics in our area. That's OB, diabetic care. We have family medicine, really anything that you needed. We are the largest trauma center in the region, and we operate as a level 2. Our region covers about 200 to 300 mile radius. So we serve all of Western Idaho, parts of Eastern and Oregon and Washington. We serve parts of Northern Nevada, Southern Montana, Western Wyoming, really just kind of all over the place. We have a very large radius and we're operating as a level 1 while still maintaining our level 2. Who here is familiar with trauma certification and designation and levels for trauma care? If you don't feel comfortable coming off chat, I can definitely appreciate that. Or sorry, coming off mute, but pop it in the chat. Or even just who's in, okay, Desiree is familiar. Who works in emergency medicine already? Silence. It's so weird being on the other end.
And if you do want, you can take yourself off mute, or as Haley said, post those right in the chat.
So those who are not familiar with trauma centers or designation and levels, a level 1 is the highest functioning trauma center that is available to our community. Trauma 2 is the next step up, but what makes a level 1 trauma center is you have all of the resources needed, you have all of your trauma surgeons, and when you think about patients that are injured, people go straight to trauma surgeons or emergency department physicians, but it's really a whole team dynamic of people and surgeons caring for traumas. You have vascular surgeons for people who come in with amputations, partial amputations, if they have vascular injuries due to penetrating injuries or blunt injuries. So you have a vascular team. We also have an orthopedics team, neurosurgery, we have ophthalmology, a whole team of people that can come in. But operating as a level 2 or a level 1, you have to have 24-hour availability to care for these patients, and it has to be on site or within 30 minutes. To operate as a level 1, you have to be working with a medical research or study facility. So we are not tied to any medical universities, which makes us a level 2. And we also do not have a burn center. But things that also tie into that are your resources available, how much staff you have, bed availability, OR capacity, ICU capacity. All that ties into becoming a level 1 or level 2 certification. So we operate as a level 1, but we do not have residents, and we don't operate with a research facility. We also do not have a burn unit. Here in Idaho, we partner with the University of Utah, or AirMac, which is Eastern Idaho. Those are our closest burn facilities. We'll just move past that. Okay, so a little bit about myself and why I came into healthcare. I don't know how many of you knew 2.5. Oh, sorry, I'm just reading comments at the same time. I'm a squirrel. I get easily distracted. Pete's trauma. Great. Okay, so we have some people that are familiar with ED. I don't know how many of you knew what you wanted to be when you were growing up, but I knew I was going to be a nurse from when I was this big. My mom was the most amazing, magnificent nurse you would ever meet in your entire life. She was an inspiration for many to come into the medical field. And for me, I just wanted to be my mom. She was an ED nurse for 35 years before she moved on to selling medical equipment. And she was a flight nurse for AirMed, which is the University of Utah's flight team down in Utah. She did that for 15 years. And the smell of jet fuel is a little nostalgic to me. She used to come home in her jumpsuit that was all blacked out. Her hair would be sweaty and greasy. She had a mullet. It was the 80s. It was a whole vibe. She'd be flipping that in the wind, and I would just stare at her in awe. And listening to her stories about doing escharotomies on patients that were suffering burns, and it's only her and a medic in the back in this helicopter, or how she had to perform a crike on a patient that had jumped over an overpass and landed on the freeway, and her team shut down the entire freeway in the middle of rush hour, and she couldn't get an air around this patient, so she performed a crike. And being a young person, I was probably 5 or 6, I ate this up. This was my bedtime story, and my mom was the most amazing nurse. So I always knew I was going to be a nurse. I wanted to be an ED nurse and a flight nurse, just like my mom. When I was in high school, I was, I think it was my graduating day, because we had a graduating dinner. It was on the day of my graduation dinner, graduation day, whatnot. We were all sitting in the Wendy's parking lot, because that's what we did as young hooligans, and that's what our hangout spot was. And one of my very good friends was coming down the hill on a skateboard. He was coming down to meet us, and he spun out and went into the street, and a car hit him. And me and another guy that we were hanging out with saw this and started running towards him. And he stood up in the middle of the street and got hit by another car. By the time we got to him, he didn't have pulses, and me and this other kid in my grade were doing compressions and mouth-to-mouth CPR on him until EMS arrived. And when EMS came, he was pronounced dead on the scene. And for me, I wanted to be better. I just thought to myself, if my mom was here, he wouldn't have died. And I made a promise to myself and to those who I was caring for that I would be the best person I could be. I would be as smart as I could be. I would find all of the knowledge and the tools, all of the education I could soak up so that the next time that happened, I was better and that I knew how to care for people appropriately and that wouldn't happen. Obviously, now getting into healthcare, I realized that was not always the case, and we do lose people. And it's always learning from those mistakes and learning from our experiences of how we can be better for the next person. So that was my healthcare. That's why I came into emergency medicine. I have a strong passion for emergency medicine. I've been working in an ED since I was 18. I graduated in 07 and started as a unit clerk. Once I got into the position, I got my EMT and started working as a tech in the department. I did so much with my EMT and I learned so much. I did stress echoes and stress EKGs for the hospital. So I was doing cardiac rhythms. I went and did EEGs with our sleep lab. I did a lot of EMT and EMS liaison and outreach. And then when I went into nursing school, I was the first LPN hire with the small community hospital that I worked at. I was their first LPN hire into the ED in 16 years. I was probably their last. They probably learned a lot of lessons from me. But then I moved into my RN role and I stayed at that community hospital for 12 years before I moved over to Intermountain Medical Center. I don't know if anybody's familiar with that. It's a big Trauma One center down in Salt Lake City. And I worked at Intermountain Medical Center for about 5 years. And within there, I was the practice shared leader. I know that doesn't mean anything to anybody because if you don't know, but I oversaw STEMI and stroke, trauma, codes, sepsis, infection prevention for our emergency department, and eventually rose into the practice chair for all of Intermountain Medical Center's emergency department. So I oversaw the process for that for, I think it was close to 100 EDs. And that kind of landed me here. I was looking to get out of bedside right after COVID. It kind of burned a lot of people out. And I knew that I wanted to remain in emergency medicine and I still wanted to provide an impact and shift my nursing from caring to patients to caring for colleagues and how that would look. And this position was opening up here to take a management position. And I thought I'd shoot my shot and see how it went. And 2 years later, I'm still here. But back to my slideshow of just why emergency medicine. It is one of my biggest passions. I think it gives you just enough adrenaline rush and just enough compassion to meet and build that connection with people while maintaining that fast pace, stabilize and mobilize, get people out of the apartment. We are the jack of all trades and the masters of none. And to me, I can provide enough support and care for my community that I live in and the community I serve without having to spend days with my community and the family members. So I do want to hear from a couple of people. I know that we're nationwide here. I myself went to WGU. I graduated with my bachelor's. So I'm happy to be presenting here and kind of have that camaraderie with our alumni. But I want to hear from a few of you what you're currently doing in your practice, what you are looking forward to, where you want to go in life, and what barriers are you finding to getting there? This one come off mute. Yeah, I want to hear you guys. Oh, I'm going to start picking on people. I'm good at this too.
Hello, my name is Desiree. I'm not on the camera, but I do want to share something.
Thanks, Desiree.
Thank you, Haley. Thank you so much for sharing. What an amazing story. And I love how your mom affected you. I think that's amazing.
Thank you.
Very proud of you.
Me too. You know what? She'd be proud. But yeah, Desiree, you are currently in, let's see.
California.
California. Okay, what are you currently doing? What do you do with your life?
Currently, right now, I have a little over a year of experience. I have a little time off because of school. This is my last term, just trying to get my BSN. But I'm going to be starting back in telemetry next month at like a level 2 trauma center. But I'm just going to be in telemetry for now. I will be afloat. And my goal has been the ICU. However, I've always been interested in ED, and I always want to be available for an emergency. I want to know how to handle them. Even disaster relief services, that is something that I'm interested in. So I'm always very interested in learning how to be a better nurse, and especially emergency nursing, I think is really part of what I want to do.
I love that. And what draws you to the ICU?
I also really appreciate being able to take care of some people, very closely, where you get to spend more time with them in the sense that you really know their history. You're going to be thinking about, what are all the complications that are going to happen? What could happen? What has happened in the past? And you kind of get to be with them for a longer period of time and follow them, even if it's just for a few days, or it could be a few weeks. So I just like really, really close monitoring.
I love that. And for me in the ED, it's again, we stabilize and we mobilize and we push those people out, and I don't get a chance to make those connections with families. So I do appreciate that, and really making that connection with people, because we often forget we're so focused on the tasks that we complete and the physiological aspects of medicine that we forget that compassion is the heart of nursing, and it's the art of nursing. It's embedded into everything we do, and making those human connections and getting back into why we went into healthcare. It's all to serve people. And I think that's great. I love that you had mentioned that, to get to know their history and their family. That's what nursing is all about. We are at the bedside more than anybody else in that facility, or more than anybody else in the hospital. And getting to know these patients, we're their first advocate and we're their last line of defense to make sure that nothing happens to them. So I think that's wonderful. We've got somebody in the comments here that's currently working on their BSN. Main area of interest is the NICU and ED, and thought it would be interesting to hear their perspective who's experienced it. And I love that, because I have a great story. My best friend and I, we went into nursing school hand in hand. I was going to be an ED nurse. She was going to be a labor and delivery nurse. We had it all planned out, and we knew exactly what we wanted to do, until we did our labor and delivery rotations, and we got to assist a birth. And immediately I was like, yeah, this is why I'm not doing this. This is gross. And my friend was like, absolutely not. I don't want to do this. It's hard to see those things until you're actually experiencing it. So you have no idea what you want to do with your life until you're in it and experiencing it, to realize like, oh, maybe I don't want to be with the babies. I don't want to be with the women. That's not my thing. And I do like, being open to the experiences that clinicals offer you and finding out from people what they enjoy about their job. And it's all about matching personality and what you can handle and what you can't handle. So I think it's great to listen to people who work in the field and to get their perspective on it, so that you can decide and make, educated guesses on what you want to do. And even more to that, healthcare offers such a broad expanse of positions. You can do anything. The world is your oyster. And I hated when somebody said that to me, but now I say it all the time, because the world is endless in healthcare. You can go on to education and nursing. You can do administration. You can continue on with education and get your NP. A lot of people come to us for CRNA. You can really go anywhere. So that's great. There's lots of comments coming in. Okay. Private care and working on BSU or BSN. That's great. Private care. You'll have to explain more to me on the private care. Can't come off mute. Maybe put it in the chat. Looking into geriatrics, looking for something new. Oh, I love geriatrics. I have such a tender heart for our elderly population. When we were doing rotations and getting into the nursing homes, it wasn't everybody's favorite, but for me, it gave the opportunity to hear people who have experienced life and to get them a chance to tell their stories, and just watching them light up as they tell you about, World War II and fighting. A lot of them were talking, about their family and their grandkids and what makes them happy as I'm giving them a pedicure. That was one of my most rewarding times during clinicals, was spending time with our geriatrics. So I love that. Community health worker, working in Medicaid and case management for Aetna and CVS. Paramedic, so that's cool. Working as a paramedic in the ED and a critical access hospital. Oh, these comments are coming in. Sorry, I'm sitting far away too, so I'm trying to read as it's going. You can tell that I am a frazzled ED nurse brain. My brain jumps everywhere.
Haley, do you want me to read some of the comments? Would that
yeah.
be easier?
Yeah, I'm so far away from this. I'm trying to
Okay,
stay
yeah,
far
let
away
me
from my computer because I talk
read
and then I get
some.
red and then I get embarrassed. So I'm trying to stay far.
Okay. Let's see which ones we just got off here. I'm a community health worker in Medicaid cases management for Aetna CVS Health. I've been a paramedic for almost 10 years and work the weekends as a paramedic in the ED. Is that the one you just read?
Yep.
Okay. Jessica says, yes, I've been told that as well. Clinicals will be talking about clinicals. People love the world's the oyster comment. So Elizabeth says, I'm working on a BSN in hopes of working with accreditation organization. I am currently an accreditation specialist to help individuals prepare for Joint Commission and state surveys.
Oh, awesome. I want to hear more about that because we always think JCO is very scary, and I like to think of them as partners in healthcare because they're helping us keep us honest and to make sure we're doing the best practice. I want to hear on the other end what you're feeling. Everyone thinks JCO is such a bad thing, and I love it. I love our accreditation.
Hi, this is Elizabeth. Exactly what you were saying. I really see them as partners and sharing best practices. They've been a lot more collaborative lately, so that is absolutely wonderful. But yeah, it's all really focusing on patient care and patient safety and staff safety. So we really, when you have a good relationship with them and you work hand in hand, it really just improves services for everybody if you think about it in that way.
Yeah, I love that. And we always get nervous because we want to make sure that we don't let our team down and our community down. And we just had our JCO survey back here in September. And of course, they come to the ED first. That's what she told me. She said, we're going to the high risk areas first because you guys always have a million things. And I was really proud of our team. We had just two low risk findings. And one of them was like a gas valve shutoff that wasn't labeled. And then the other one was one of our patient family members put food in the fridge. We watched them do it and it wasn't labeled.
That's amazing.
I know. So for an emergency room to only have two things, it was like the team worked so hard and it was so proud. And it really is the name of patient safety, and patient-centered care should always be the focus. And it shouldn't be a scary thing of, they're going to cite us for this and this. It's not something that you do to prepare. You always do it. So I love that.
How do you help staff deal with like work burnout and things like that? And then is there anything like additional training or education that you provide for patients that may have behavioral health issues? A lot of times our behavioral health individuals get kind of ignored for their medical because it just gets attributed to behavioral health.
Yeah. Okay. So that was a two-part question. So burnout and psych health. Okay. Let me write it down because I will get us off track because I like to talk. So burnout is this is widespread. Everybody experiences it at some point in their career. And how do you help support people that are going through burnout? My whole approach is to prevent burnout. And especially when we're talking about supporting colleagues, it's watching out for those warning signs. So there's a two-end thing to this. When I was a bedside nurse and working very closely with patients, my burnout started happening when I was going through COVID. And it's not something that happens immediately. And it's not even the big patients that happen that come in and just rip your heart out, or the one patient that's spitting on you and hitting at you. Burnout is a slow burn. And it's something within yourself that you have to recognize and realize that it's happening within yourself and not ignore it. And really focus on healthy coping mechanisms, whether it's getting out and doing what you enjoy on your weekends off, talking to the therapist, working out. Some people love going hiking and swimming and doing outdoorsy things when they're on their time off to help decompress. The hard thing is that healthcare offers no psychological safety in what we do. We are exposed to and see and do horrific things. We do have to do horrific things to people to keep them alive. And there's no safety in it for healthcare workers. And that offers large gaping opportunities for mental health issues to sneak in, for burnout, and for, just burnout in the profession in general, not even in your specialty, but in the whole healthcare in general. So for me, it's important to take care of one another and to make sure that you're offering support for each other, because nobody knows better what you're going through than the person who's sitting next to you. Making sure that you have healthy coping mechanisms and really just digging into your why. Healthcare is hard and it's hard to stay in it. And for me, I go back to that moment of when I was doing CPR on my friend and really just bring myself back into why I'm doing this, and remembering that it's the community I serve, and I made that promise to myself. And that helps kind of recenter what I'm going through and bring me back off of the ledge. But burnout is a very real and a very significant issue that we deal with, and it's not one person's problem, it's all of our problems. So that's from a bedside perspective. As a leader perspective, it's really about taking care of my people and making sure that I am providing, even just on shift of lunch breaks, rounding with them and seeing if they're okay, taking a few tasks that I can do off of their plate without asking. I think that's a big thing, is when you ask people if they need help and they say no, they're okay, but they have a huge list of things to do, just going and doing it and letting them know that you're sharing their load and sharing their support. Also making sure that I have EAP, or our chaplain services, for trigger patients, and I have them early so that when they walk out of that patient room, they have somebody who can comfort them and help them right off the bat. And just letting people know that it's okay to not be okay. I think ED gets a bad rap of being the hard exterior, the bristly people in healthcare, and it's, those are the people that we need to take care of the most. They have that hard exterior shell in the ooey gooey center that really gets burnt up and toasty in the middle. So I think taking care of one another is very important, and taking care of your people and just not only telling them that they're there, but actually being there for them. And then, sorry, see, I got a sidetracked. Psych help. In our department, we have social workers that are present in the department 24/7, and I pride myself on my social work team. They are the most intellectual, capable people, and we have a whole system built around to support our behavioral patients. We have a committee in the department that gets together and we talk about support and resources that they'll need. We meet with our community partners every week to see how we can improve the system back and forth. There's some things that we need to improve on our end to make sure that we're sending patients there safely. And recognizing that these people are some of the people in the community that don't have a strong voice, and how are we their best advocate? We made it a policy. I hate the word policy, but it's more patient safety of giving these patients dignity while they're here, because they can be here for days on end. So making sure that we can safely shower people, offer them ADLs, getting them up to brush their teeth, treating them like human beings, and really getting back into why we do this to make sure that we're providing safe healthcare. So that was a long walk for a short drink of water. I hope that answered your question.
Thank you so much.
Yeah, of course. That was a great question. I love that. I like questions. Let's do questions. I can tell you all the things later.
Hi.
Hello.
Hi, can you guys hear me?
Yes, we can.
Oh, okay. Hi. So my name is Zoila. I'm from California. So I'm a med-surg telemetry nurse. I was there for a little bit. I enjoy what I did. I'm taking some time off. I do plan to go back, but I know that my heart is in the oncology unit. That's where I really want to go. And that's because I've been going through some stuff lately. But oncology was something that I didn't even consider years ago. I wanted to go into mental health, but I know that oncology is where my heart is now. So, and I'm a student at WGU, so hopefully graduating soon.
Oh, I love that. I love that so much. My sister was, again, one of the great ED nurses. She and my mom trained me, and she went on to get her NP, and she thought she was going to be an ED NP and work in the emergency department forever. And we had this one patient that came in with very vague symptoms, just a little bit of insomnia, night sweats, shortness of breath, and quickly realized that they were in stage 4 leukemia. And it from this point, we admitted him into the hospital and started emergency services with them, with our cancer institute. So while they were in the ED, they came down to start preparing this patient, and just the trajectory that this patient had, but the support, their prognosis was very poor, but the support that was given to this patient really latched onto her. And she's now in oncology NP and has been for, oh goodness, say like 7 years now. And I have a very soft spot for oncology nurses.
Yes, that's how I feel. I feel that that's what moved me into wanting to do that. I feel that the nurses that have been treating my dad, they've been great, and they've been a great support, you know, in those moments where you're scared and you don't know what's going on, but you have those nurses being nice and you're seeing that they're treating him with care, and the words they're giving you, it changes everything. So.
Oh, I agree. And then I'm sorry to hear about your dad. It's scary, and it can be life-changing, but I'm glad that he has support and that you can actually have that visual of the art of nursing in action and that compassion. It really brings healthcare to a whole new level, and getting back into caring for people and not the diagnosis, but people. I love that. Thank you, Zoila, for sharing.
Of course. Thank you. Thank you.
Who else? Don't be shy.
I have a question.
Yeah.
How long, well, it's a two-part question. So how long did it take you before you really felt comfortable, you know, being in codes and implementing certain measures, whether it was sepsis or trauma or stroke or
Okay.
and what did you do to prepare? Because I think it's so awesome that you had your mom and your sister there. And I think that training is a huge part, and who's precepting you. It's a huge part of what's going to happen while you're there and how you learn. So I would just love to hear your answer for that.
I love that, because preceptors, you know, we always look to our preceptors and who trained you, and it can make or break your whole introduction into healthcare. So for me, time for comfort, I would say it was a good year to year and a half working in the ED until I really felt okay, just okay. I had also been a tech and an LPN in the department for 9 years before I got my RN there. 8 years, somewhere around there. So I had already been comfortable with the people I was working with. I knew them, but having that responsibility, it took about a year and a half until I finally felt comfortable and prepared for what I was dealing with and had a good routine. That changed when, of course, you have time-sensitive emergencies and patients that are a little bit more sick, like you said, your sepsis patients, stroke. I would say never let yourself feel comfortable. You can feel okay, but you always have to have a healthy level of fear when you're taking care of really sick patients, or even just patients in general, because that healthy level of fear will keep you safe. You'll triple check your doses, you'll triple check your medications, how you're giving them. It will keep you and your patient safe to always have a little bit of discomfort when you're in those rooms. So I would say until I felt comfortable in time-sensitive emergencies would probably be about 2 years. It took another year to really fully understand. And especially there's just a lot of metrics and a lot of time-sensitive interventions that need to occur, and how we document those. It took probably another year until I had that down and I was okay, especially with strokes and trying to get those Q15 vital signs documented with neuro checks, feeling comfortable in my own assessments. And I think that was a big thing I had to get over. Was I had to be able to trust myself and to know that I was smart and that I was capable and what I was doing was the right thing, because I was second guessing myself constantly. Like, what if I miss this, or if I'm assessing this and what if it goes wrong? And right off the bat, out of nursing school, right off of orientation, it was one of my very first patients by myself. And at the time, like, this was a very small community hospital. It was a big ED. We had 28 beds, but there was only 3 nurses for 28 beds. So just laying that out. And one of the nurses was the triage nurse. The other one was the charge nurse, and then just drone nurse, whatever you were doing. So I had a patient that came in. He was 36. I will never forget his name. I will never forget his, like, how old he was and what happened. He was 36 and he had started getting shortness of breath and called EMS. EMS arrived and he was a little bit mottled. His SpO2 was low, so they threw him on a nasal cannula, and the patient said that helped a little bit. And by the time he got to me, he was pretty mottled, so I threw him on a non-rebreather. Got an EKG, showed the physician. Physician said, it looks kind of funny. Let's just repeat this in about 20 minutes. And working as the floor nurse, 20 minutes, I can go and do 2 other IVs. I can settle another patient. I can do a million other things in that 20 minutes. And I just had this feeling to stay with him. And so we just sat there and chatted. I got to know him a little bit. And probably about 4 or 5 minutes after that, he looked at me and said, something's not right. I don't feel good. Something's going on. So I was like, perfect. Let's just repeat your EKG now as you've got changes happening. I started hooking him up to the EKG machine, and he looked at me and he goes, no, something is wrong. Something is really wrong. So I stepped out of the room. It was like 2 steps backwards. I step out, pop my head out and say to the doctor, Mike, hey, I need you in here, and turn back around and he's purple and seizing. So in my brain, I'm like, ah! So I run out of the room, have to run and find the crash cart, come back in. And by the time I get in, he doesn't have a pulse. And we coded him for about an hour and a half to 2 hours and never got him back. And for me, I was brand new off of orientation. I didn't have my safety net of my people anymore, and it was just me. And I tore myself up about that. I thought if I had been a more experienced nurse, or if I had done more, or if I had the crash cart at the bedside before he started coding, if I had just done more or been more, he wouldn't have died. And to hear yourself telling yourself that as you're a brand new nurse and providing that deprecating information and tearing yourself down, it's really hard. I don't know where I was going with that, but it's a story that I was having. Anyways, to have that level of discomfort and to not know, or to feel like you didn't know what you were doing and to feel like it could have gone better is really hard as a new nurse. And giving yourself that grace, I look back now and realize this man was already landed in a very poor position, and he served a better chance with the team there rather than me feeling like I could have done more to save him. I did everything I could. So learning to prepare for that and looking back and seeing the steps that you did do, the ones you didn't do, use those as learning opportunities and how you can make yourself better. And preparing for those situations, I feel like to me is not black and white, but it's simple. There is lots of education out there. There are lots of experiences. You have to jump in and do it. Provide yourself as much education as you can. This is the perfect platform. You're in school, you're learning, you're trying to make yourself better. Learn as much as you can and use that information. It's provided to you, it's there. The hospitals that you work at have continuing education. Your preceptors, latch onto the smartest person you know and ask them a million questions. You can ask a million questions, but you can never ask none. When you're not asking questions, that's the scariest person. On the back end of that, when you start moving into feeling comfortable and you start precepting, be the preceptor that you wanted somebody to be for you. Really do your next colleague and your next generation of nursing a service and treat them right, show them a good introduction into healthcare, and show them everything. Get them into things, get them experience, teach them how you wanted somebody to teach you. And it's the golden rule, treat somebody how you wanted to be treated, but precepting is so important. And I feel precepting for me, my preceptors were the cream of the crop. Like, not just saying it because my mom and my sister, but I also worked with phenomenal nurses who had, and thankfully for me, by the time I came into healthcare, we still had seasoned nurses around. But I was trained by nurses who had been doing it for 15 to 20 years. And taking somebody under your wing and telling them it's okay to make mistakes in healthcare. It's okay to make mistakes, report them, and learn from them was one of the biggest things I learned, so that somebody else can also learn from your mistake. And I think that's really important now as we start seeing more criminalization in healthcare mistakes. Never stop reporting your mistakes, and always let there be a safe reporting culture. Wherever you're going, if you're interviewing for people, if you're asking about jobs, when you're asking questions, ask what their reporting culture is like and make sure that it's a safe reporting system. Again, I get off on tangents. I'm so sorry, but I hope that answered your question too. That was a great question.
Thank you. That was really helpful. Thank you so much.
Yeah.
I love the story because I don't know how everybody else feels, but I feel like stories help me to remember things.
Yeah, and it's experience, right? Like
way. Like
I
big
love
symptoms
stories.
for the the young person that your sister had taken care of, and even what your 36-year-old patient was going through at that time. You could, certain things you could just never be prepared for, but we do have to be prepared to not be prepared. You know what I mean? We have to
Yep.
be, people are going to come in with vague symptoms. And I just think of my, really quickly, is my one very fresh, for sure, a stroke patient. He ended up having a hemorrhagic stroke and he seemed really fine. He just had the high blood pressure, but he was doing really well as far as the strokes go, which I'm really learning how to really get better at. But I don't know, I just think about that, like you wouldn't really think that was really going on, but it was.
Those patients are so hard, and it's the patients that are very sneaky. Those are the ones you have to watch out for. It's the sneaky patients. They come in, and I call them star patients. I won't swear on an academic meeting, but it's, S word. That ain't right. And that's my star patient. You don't know what's going on, but you know something's not right. And that's really one of ED nurses' skills is, we have a lot, time management, triage, but detection of deterioration for patients that are sicker and sickest, and to really watch out for those key changes. And how do you trend patients, and what are you watching out for as you realize they're decompensating? Or even patients that you come in and you're like, you could be fine, but are you fine? And it turns out they have a full-blown hemorrhagic stroke. And really giving yourself the grace that you are there with your patient, you're watching for things, and you're being their biggest advocate. And I will tell you, stroke assessments are very complicated. They seem very straightforward, but they can be very complicated and convoluted. So really latch on to all the education that you can. And again, find the smartest people, ask them a million questions. And that's why we call it practicing medicine. It's not perfecting medicine, it's practicing medicine, because it's always going to be changing, and we're always going to be learning, and we're always going to be growing. So keep asking questions, and really you have to get comfortable with yourself and start trusting yourself. And once you start trusting yourself and you start trusting your assessment skills and building up on those, that's when you're going to start feeling more comfortable. I love questions. Can we just do questions the rest of the time? I want to hear from you guys. I don't like hearing myself talk so much. What other questions do you guys have? Don't be shy too.
I don't have anything else in chat, but I'm happy to read.
Okay. If there's no questions, we'll kind of just keep going on with the slideshow. I like talking about emergency medicine versus other departments. I am a one-trick pony. I only know emergency medicine. It's all I've ever done. I've never experienced other things. I think it was Desiree that mentioned wanting to work in the ICU. That was I was my own barrier to flight nursing. I knew that I had to have ICU experience for flight nursing, and I just did not want to do it. I could not bring myself to care about a MAG potassium protocol. I know it's bad. I couldn't bring myself to do it. Dressing changes, bed changes, that wasn't for me. So I was my own barrier. However, healthcare is so unique and dynamic that I know emergency medicine isn't everything, but for me, this is all I know. So I'll speak a lot to emergency medicine. But the unique attributes and common qualities of colleagues that work here is we are very fast-paced. I kind of mentioned this a little bit before, but we have very specialized skills in every specialty you go to. That's why it's a specialty. You have specialized skills, but we are the jack of all trades and the master of none. We have to know a little bit about everything to get the patient out, and stabilization and mobilization. So we have to work very strongly and closely with STEMIs, strokes. We do a lot with trauma, obviously. We're the trauma center. But we have many veins that we see patients through. And one of my personal favorite patients to care for is actually sepsis. I think sepsis is so intriguing and dynamic, and you have every system that's affected by it. And there's a very clear process and very clear criteria to watch out for this and for early identification to start treating sepsis early. and to watch your progress unfold before you. You start trending lactics. You can watch your blood pressures improve. You can see patients become more cognitive and aware. And just having to think about, comorbidities and what am I giving with antibiotics? Can their kidneys tolerate this? Are they going to go, septic shock? Are we worried about their liver and watching their urine output? And watching for dysrhythmias and everything that can be affected by sepsis. It is one of my favorite patient complexities and diagnoses that we work with. People come in, they're ambulance chasers. They just want to get into the nitty gritty traumas. But for me, I call it my trauma Rolodex. I've been doing this for a very long time, and my trauma Rolodex is full. I have a lot of sad stories in there that I can sort through and deal with as I need to. But the trauma is not what brings me to emergency medicine. It's everything. We do so much, and I love a good sepsis patient. So sorry, I get off on tangents. Triage is one of our specialties, and I think that's the most underplayed and resourceful tool that we have under our belts, is that sicker and sickest. And, it's not first come, first serve. We sort through who needs what, and we really have to make very fast-paced, quick judgments on people walking through that door, if they really truly need emergency attention now, or if they can wait 10 minutes, or if they can wait 30 minutes, 40 minutes, however long they're out in the waiting room, and being able to adapt and change as patients change. Time management and prioritization is another one of our skills. For the ICU nurses that want to go and explore their one patient, we have 4 patients that we are trying to manage and keep alive, and having to bounce between the 2 and keep them sorted. That's how my brain operates anyway. I don't know if you've noticed anyway. I'm kind of a squirrel, but I jump between threads, and it's because I have 4 different scenarios going on in my brain at the same time, and I like intermixing both of them. But so 4 patients, 4 different things going on. You could have one patient who's a little old Betty, and she fell and broke her hip, and she just needs some ice chips, and she's in pain. And you walk into the next patient's room, and it's a sexual assault patient, and this is the worst experience of her life, and you have to work through that trauma mentally and physically with her. You go into the next patient room, and it's a testicular torsion, and now it's a life-threatening emergency, and you have to hurry and get them pain medication and get them off to OR. And you can have all of these different emergencies and all of these different experiences within 10 minutes. So for me, time management is huge. And especially if you're wanting to come into the emergency department and you're working on how to get there, start focusing on these skills with time management, prioritization, triaging your own patients and determining who's sicker and sickest and who you need to see first. And we've kind of already gone through stories, but cons for me working in emergency medicine, we touched on this a little bit, but it's burnout and workplace violence. Those are the 2 biggest contributors for dissatisfaction for me personally and a lot of our healthcare workers. I think it's never appropriate for somebody who wants to come in and help the community and help serve patients and keep people safe for then in turn to turn around and punch and hit us and kick us and spit on us. So I have a really big focus on promoting a culture of safety in the department, and safety is a huge net. It's safety for our patients, it's safety for reporting, and it's safety for our colleagues. And I don't take that lightly, and I have a constant focus on how we can improve and how we can better keep our patients and our colleagues safe. And when I say we take care of people, we take care of our colleagues and our patients, and those are the people to me. And there's not one over the other, and we have to take care of each other. So those are the 2 big cons for me. Other departments, I know it's on here, but I can't really speak to other departments in the hospital. We have talked about oncology and ICU, and there are so many veins in healthcare, so many different avenues and specialties you can go down. And as I said earlier, the best part about it is that if you aren't loving or vibing with what you went into, change. You can go anywhere. Okay. So as I said, this was not made, I didn't make this, it was more made to tailor this. We're just going to blow past this. This is coming in as EMTs. And that's my slideshow. But I want to hear more from you guys. I know that we have people all across the country. I want to hear what you're facing in healthcare and where you want to see it go whether that's in your own unit or just broad expanse of your understanding of healthcare, where you want it to go, who do you think you can have pull into that, the key stakeholders for who needs to be involved in that. I know that was a very large, multifaceted question, but to simple it down, what are your dreams for healthcare? What do you want to see happen in the next 10 years? Don't be shy.
I'm actually probably one of your older students that, you know, decided, oh, let's go get a nursing degree and what are you going to do? And, you know, I wanted to be a joint commission surveyor, but now it's like you're getting closer to retirement age. So is that something that's feasible, or what do you want to do? And I always enjoyed that process of caring for individuals, not only the patients, but also staff as well. So I would like to find something in leadership, but I'm not 100% sure what path to go on at this point in time, especially thinking of my age and, you know, where I'm at. So it's just a little confusing of, you know, okay, I'll get this degree, but then what's my next step after that?
So depends on where you're landing. If you stay with accreditation, I don't know. However, age is nothing but a number and opportunity and experience. So don't let that deter you. Some of the best nurses I know are well into their 60s. They've passed retirement and they are still cooking. And when I say latch on to the smartest people you know, those are the smartest people I know. They have all of the tips and tricks, and seriously, so don't let that deter you. I won't get off on another tangent, but getting into where leadership should push everybody or where you can go with that, see what's available within their, when you're getting hired on, or if you're currently working somewhere, see what leadership opportunities there are and where there are opportunities for growth. For our department, you can start as small as you want or as big as you want. When I got up here, we set up 8 different committees. You can be the lead of any single one of them. And I work closely with my leads to help build their leadership skill and to start getting that process improvement, that leadership dynamic of working with other people, different personalities, big picture vision and where you want things to go. And that's just a small scale leadership in the department, and it moves up. You know, you can be a charge nurse and then moving on to supervisor, management, and then from there you can go anywhere. There's project managers if you want small scale, low span of control, but you want something that you can control in. So project managers, department managers, you can go on to directors. If you want to stay out of healthcare organization, accreditation also has department leads, managers, really anywhere that you want to go, there's growth and leadership within that. You just have to find out the small scale and really start building on those leadership skills. And I highly suggest, if you haven't already thought about, moving towards your MSN, and as you're in that progress, identifying who you want to be as a leader. There are many different leadership types, and I think every single person, every individual needs a different leader. And that's really important when you work with large groups, and how you interact with people. It has to be different for every person. I don't know who has kids on here, but I can't be the same mom that I am for my 10-year-old as I am the 6-year-old. I'm the same person, but I can't be the same mom. I love them the same. It's different. It's the same with my kids out there on the floor. I call them my meth head kindergartners, all my adult children out there. But I can't be the same person for every single one of them. Some people I can be very direct and pointed with because they need that. They need it very clear cut and dry. And other people need a softer landing. So really developing those leadership skills, talking with people, conflict management. A big one for me is process improvement, and again, caring for colleagues. I think anywhere you want to go, there's growth opportunities, and there's chances to move in any direction you want, whether it's education, administration, or just getting higher degrees. I think you can move in any direction for anywhere you go.
I noticed that, and I don't know why, but my mom was a nurse, and I was looking into nursing, but it's like, can I really handle all of the fluids and things like that? And I thought maybe not, maybe I'll go into behavioral health. So that's the path that I went. But when I saw, when you're job searching and you're seeing the different types of opportunities, I wish I would have gone into nursing earlier, because that would have really given me more opportunities to, work in the field, but then also potentially move into leadership positions and things like that. So I'm a little bit behind the ball on that, but it's been fun.
You're never behind. You're never behind. You're right where you need to be, exactly where you needed to be.
We have just 3-4 more minutes. So if anybody does have any last questions for Haley, please feel free, come off mute or post those in the chat.
Questions on NIHSS and how to best assess the patient for accurate scoring, even if you don't have a form to go off of. So I remember with just neuro, you want to be checking. I don't know how many people have done TNCC for me, but for me, for every assessment, it's touching, feeling, asking the patient, touching and feeling, but putting your hands on the patient and helping them. So it's touching their face. You're going to try to get their nerves and see if they have the same sensation, asking them to move their face. You can even, it doesn't even have to be the normal, like raise your eyebrows, close your eyes. It can be whatever you want to be. I usually puff my cheeks out and ask them to puff their cheeks as I'm tickling them. I do that both at the same time very specifically because it's two different things and two different nerves happening at the same time. And I want to know if the patient has that nerve connection to differentiate what's happening and what I'm telling them to do. If that's not there and they are not able to complete that two-step assessment, then I move on to more basic things and realize that there's a deficit going on. But there are NIH education and assessment scores out there for education. Really latch onto those. Even if you don't have the forms, it's just remember moving from head to toe, touching your patient and asking your patient to do the same things that you're doing, mimic what you're doing, because that lets you know if they're computing information, and it'll let you know if they're doing this, you're like, okay, obviously you've got some sort of nerve breakdown or nerve block happening, that they can't perform the same functions that you are. And it's also the computing. So it's a multifaceted assessment, which is why I said it's very convoluted. But really it's going from head to toe, touching your patient, asking them if this feels the same, does this feel the same, does this feel the same, sensation all the way down. Ask them if they can raise their arms. If they have any sort of drift, then you know that they more likely have a large vessel occlusion if there's any sort of drift down on one side. Also assessing their speech and how they're articulating and their communication. I think, I might even have education that I can pop in here. I know that what I'm saying is all over the place and it's really hard to go through and show an accurate assessment as you're not physically touching somebody or showing somebody and having them replay it back to you. So I'll see if I can post education in the chat. I think I got it off of the NIH website. That might be helpful.
Thanks, Haley. I appreciate that. And fortunately, because I have done them before, but I'd like to be comfortable doing more. What you're saying does make sense, but for those of us who have not done stroke assessment yet, I can see where you're that education.
You can see where my brain's going.
Totally. No, I totally understand.
Do stroke assessments on normal patients that aren't having stroke-like symptoms. Do as many as you can so you start feeling what normal is. And then when something happens that is abnormal, that's different from routine and different from what your normal assessments are, and that will flag you to something's going on. So do as many as you can on normal, healthy people so that when something happens, you're like, oh, this is different from baseline.
Awesome. Thank you. Great suggestion. Thank you so much.
I just wanted to jump in. Haley, thank you so much for jumping on and answering everybody's questions. I know for me personally, I prefer these types of sessions where it's just a Q&A and you're just sharing your knowledge. I find those to be super beneficial, and it's much more engaging than a slide deck as you're going through and kind of sharing that information. So thank you for being able to jump on and willing to do this. I know those that were here are getting something out of it. And then just a reminder to everybody, this session was recorded. We'll be sharing it out. So if you want to go back and reference anything that Haley shared, certainly can go back and do that. And then just a reminder that that'll be sent out sometime tomorrow. So just keep an eye out for that recording. But thank you, Haley. We really do appreciate you jumping in, sharing your knowledge. Super thrilled to have a WGU alum jump in, and it's a little bit more meaningful, I think. So we greatly appreciate that. So thank you very much.
Oh, the pleasure is all mine. I really do love coming and talking and getting a chance to speak with fellow nurses. It's one of my favorite things to do. And you guys will survive. I promise there isn't an end in sight. You'll make it out.
Awesome. Well, thank you everyone for taking some time jumping in today, and have a great rest of your day. Take care. Bye.
Thank you.